Hello to the MSU SCS poster competition team. My name is Dr. Andrew Good, a resident physician at Henry Ford Wyandotte ER. It's my pleasure today to present the case of thyrotoxic heart failure. Both thyrotoxicosis and heart failure manifest on a spectrum of severity. At the severe end of that spectrum, both carry a dismal mortality rate. For this reason, it's very important for ER physicians to recognize these diagnoses in the ER and initiate treatment in a timely manner. Without further ado, here's the case. This was a 53-year-old female with past medical history of hyperthyroidism as well as anxiety. She came in with 3 to 4 days of exertional dyspnea along with orthopnea. She had no chest pain, no neurologic symptoms, no leg swelling. Notably, she had no cardiac or lung history. On initial evaluation, she was noted to be tachycardic, tachypnic. Her workup noted a BNP of 525, a troponaemia of 282 that peaked at 1100, an undetectable TSH, a free T4 of 4.78. Her ECG showed sinus tachycardia without ischemic changes. Her chest X-ray showed cardiomegaly with pulmonary vascular congestion. The diagnosis of thyrotoxicosis and heart failure were made in the ER. Treatment was initiated with propranolol and methimazole for her hyperthyroidism, and she was given a dose of Lasix as well for her volume overload. She was then admitted to the hospital with cardiology and endocrinology consultation. On admission, a transthoracic echo showed an ejection fraction of 30 to 35%, which was a newly reduced ejection fraction. For this reason, they performed a left heart catheterization, and they noted a mild vasospasm in the mid-LAD that improved with intracoronary nitroglycerin. Notably, there was no atherosclerotic coronary artery disease on this catheterization. A thyroid ultrasound noted thyromegaly with increased vascularity, but no nodules. A full thyroid panel was ordered, and she was pan-positive. This included thyroid peroxidase antibody, thyroid-stimulating immunoglobulin, as well as the TSH receptor antibody, and this was most consistent with Graves' disease. The patient improved notably on antithyroid medications and was discharged with endocrinology and cardiology follow-up. The above patient's heart failure, with the absence of atherosclerotic coronary artery disease on left heart catheterization, was favored to be secondary to her hyperthyroidism. Thyroid storm classically mimics other diagnoses. This is an important diagnostic determination, as the treatment of thyrotoxic heart failure differs from other causes of reduced EF. 1/3 of patients with thyrotoxic heart failure will improve with proper thyroid control. Further, nearly half of thyrotoxic patients have cardiovascular comorbidities at time of admission, and heart failure represents the second most common cause of death in thyrotoxicosis behind multi-organ failure. The diagnoses of thyrotoxicosis and thyrotoxic heart failure are clinical. A high index of suspicion is necessary, especially in every new case of heart failure. Because hyperthyroidism classically mimics other pathologies, 2 scoring systems, the Birch-Wartowski point scale and the Japanese Thyroid Association score, are available but lack specificity. Moving on to our discussion, why did this happen? The most common cause of thyroid storm is Graves' disease, and incidence of this increases with age and is 4 times more likely in females. Common triggers like infections, ischemic events, medication noncompliance can easily precipitate both conditions. Thyrotoxicosis itself results from systemic beta-adrenergic upregulation and sensitivity to catecholamines due to the direct effect of elevated serum thyroxine. This is why non-selective beta blockers like propranolol are used to blunt symptoms. Treatment in the acute phase also includes antithyroid medications. Methimazole is the most commonly used, unless in the first trimester of pregnancy, in which case propylthiouracil is preferred. Likely iodine and steroids will also be administered. Definitive management includes radioactive iodine therapy or thyroidectomy. Patients will take lifelong thyroid hormones as a result, however. Patients who prioritize the possibility of remission and avoidance of long-term thyroid supplementations have greater outcomes, though recurrence of symptoms is much more likely. Factors associated with remission include mild disease, small goiter, low titer TSH receptor antibodies. 3 important takeaways from this case presentation. 1. Rule out thyrotoxicosis in any new diagnosis of heart failure. The treatment differs and you don't want to miss it. 2. Diagnosis of thyrotoxicosis and thyrotoxic heart failure is clinical, though scoring systems exist, like the Birch-Wartofsky scale and the JTA. 3. Treat in the acute phase with beta blockade, methimazole, and in the long term, treat with radioactive iodine therapy and thyroidectomy. Thank you so much for listening. I know I learned a lot in preparing this presentation. Hopefully you learned something too.